Okay, good afternoon, everyone. All right, so in today's class, sorry, I'm going to be doing this online. I forgot to say that because of the fact that last week I couldn't make it for class, and this week it's not also looking likely. And I could remember that the last time I taught you guys, it was on imaging critics, and we decided that next week I'll complete it if I'll be available next week. But I wasn't available. I couldn't be available, and I'll not also be available this week. Yeah, so I just wanted to, use this online. We finished what we did last week, like we were almost done, just remaining the second material, if you guys can remember. So I decided, okay, let me just use an online class to finish up, so that even if I will have another physical class with you guys, depending on when the exam will come, it no longer be on imaging critics. It might be on another course, if depending on your DOA, your Kennedy, and whatever you guys discuss. So I just want to use this, medium to finish what we had, from the beginning of the class. So that is what we are here for now. So concerning this, the imaging interpretation, with last class we started with the Radhanat, right? And we discussed on the structures of the chest. Yes, we discovered on the normal pathological variant of the chest. We started from how the chest to appear normally. We discussed on how to know a good radiograph. We discussed on different projections. We then discussed on the Schirrett sign, discussed on various pathologies and how to know them, even discussed on their dimensions, and we so many other things we discussed on the material we used for the last class. So now this is second material, and this one will now be more of interpretation, just similar to that of the first class, but now is now going deeper into the pathological aspect. Now, I'll just use it to wrap up, just in case of those that missed the class. I might be referring back to what we said in the last class, so that you guys that actually missed the class can actually, grab something. Although I'm not going to start going deep because I don't actually have such time. So we just move here now. Now, concerning this material, we are going to look at the chest X-ray basics, then the types of X-ray, that is the AP and AP films, then obtaining images and systematic method of reading chest X-rays, then common signs, and that is examples. Now, we are just going to rush this because I know that many of us know this, but I just want to bring it back so that we will see what we are going to use and actually learn the material. You know what about imaging critics is that you have to systematically know the beginning, that is the basics of chest, not just chest X-ray, like every part of the body. You need to know how the film is being obtained, then how to read the film on anatomical, like that is a normal anatomy. Remember, we know the normal before we go to the abnormal. If not, you won't do well in chest interpretation, because many of you think that chest interpretation is just more of the pathological aspect. No, it's not. The pathological aspect is among, but it's not all that is comprised of what image interpretation. Image interpretation can actually also consist of whether you placed your marker as well. Was this image obtained in the correct projection? Okay, this image was meant to be a PA. Why was AP obtained? Is an image, is in critics. You know what is critics? We are criticizing something. So when you hear about imaging critics, don't just think it's just visualizing film. No, you are meant to criticize an image. Just like in an exam now, and they give you, maybe during the Viva, they give you an image and they're telling you to criticize it. We are not asking you to look for, tell us the normal something. For you to criticize me, we are telling you to tell us what is not meant to be here. Do you understand? You are looking for something that is absurd, something that is not normal, something that is not meant to be here, something that is displacing something, or something that was done wrongly. That is critics. You are criticizing something. You get? You are trying to say that this was not obtained correctly. That is imaging critics for you. Or something is not normal here. Do you understand? So we know that in a standard chest X-ray, we do PA. PA is the basic projection, then lateral for foreign body, which you said in class. You get? Then you can do AP supine for patients who are what immobilized. Remember, patient we do AP for patients that cannot stand, patients that cannot obtain cannot stand to obtain a PA or a lateral. We then do AP, and most times we do lateral shoot through just to get our lateral, just in case we can't place the patient for lateral, the basic lateral projection. Now, in basic X-rays, you know that we all know this one is just the introduction part. X-rays are part of light spectrum, and unlike visible light, X-rays pass through the human body, and they pass through in the chest. They pass through the lungs without much interference, which makes them what appear what black on the radiograph, which you said in the class last time. Then those parts that are dense, that makes it difficult to pass, or such as bones, they appear what white on the radiograph. Now, in the organs absorb X-rays differently, and thus their shadow on the film is different. Like example, bone has an high absorption, as we said now, and appears what white. Tissue that is moderate what absorption, that is soft tissues have what moderate absorption, and that's why some of them appear what gray, some of them appear a kind of whiter than the other. You get, but it is moderate. It is within that denser structure and the less dense structures like or like air and the rest. Remember when we were discussing when I taught you guys CT, when I was talking about Hornsfield units, when I told that these are numbers assigned based on the what various density of what tissues, and they are assigned in units called what in a grayscale. Get, and the units used to assign this is called Hornsfield units. You get, so there we say that water was zero on a neutral position, and bone was what the highest based on density. You get, and the air was what lowest, that which is what minus 1,000. We say it in class. So tissue have what moderate what absorption appears was gray. Then air and lungs, you know that air is filled with lungs, unless in terms of pathology. That's why if you see anything that is not black in the lungs, just start thinking of pathology already, because the lungs is meant to be clear with what air. The only thing that can be seen in the lungs is the what vascular markings, or the parenchyma of the lungs is what you can actually see to appear what a kind of a little bright because of the blood contained in it. But air on the norm should be what black. You get, so types of chest X-rays you have to say our PE and lateral, that is patient facing in the cassette and X-ray 6 feet away, and those ones. Then supine X-ray 40 inches away and magnifies anterior structures and pulmonary vasculatures. You know that when we do AP projections, most of our structures are what being magnified, as we say. That is why if you do an AP projection, you should be careful not to what give a patient a pathological you give the patient kind of tell him it has cardiomegaly or the rest. No, because we are doing an AP projection. We are expecting the heart to be magnified based on what geometrical distortion or the rest. You know, when you do an AP, when a structure is far away from the cassette, the organ itself tends to be magnified. So we are expecting that. So when you are checking that, you should be careful so that you will not see that the heart is magnified based on your OFD or FFD, and you give the person what cardiomegaly. But you know that most times when it comes to technique, I also add this is that if you are doing an AP projection, just have it in mind that you are not going to use the normal FFD you are using. You have to what increase it. That is one thing, the law of geometry. Once the OFD is kind of large, you have to increase the FFD to compensate for it so that there won't be much magnification. Yes, so we go over to comparing chest protocols. Now PA we know is more preferred, and AP note enlarged, heart is always enlarged, and lungs fields are not as clear as compared to what PA or projection. So in PA films, read as if patient is facing you and patient's left side is on the right side of the what X-ray. Now this is very important. Just although we don't actually look at this because we place markers. You get, markers are there to direct you, but you know that you shouldn't rely more on markers. Why? Because even the radiographer itself, let's just assume that we are radiologists now, that we are reading the image. Radiographers, we can make mistakes. We can go and place a marker on the wrong place. So you don't actually need to rely on the anatomical marker to know where the patient's left is and where the patient's right is. No. And also, people normally use the heart to identify, because we all know that naturally the heart should be on the left side, but that is a lie, because heart is not everybody's heart that is on the left side. That's what we call dystrocardia, where the heart is shifted to the right. Do you understand? It's not a must that the heart will be on the left. There are people that, based on nature, their heart is on the right, and it's not actually pathological. It's not based on what embryological deformity, or the way, like, some people just have that, deformity or something. What will I say now? Like, let me say, it's just nature. Yeah, it's not really pathological, but it just happens that way. So you don't use the heart to judge that, okay, this is right and this is left. No. You get, so what we need to do is that for you to know that, okay, this is patient's left and this patient's right, you have to make sure that the patient's left side is on the right side of what the X-ray. Read it as if the patient is facing you. You get, so that means if the patient is facing you, your right should be the patient's left. So obviously your right side of your hand should be where the patient's left side is on your radiograph. So whatever your right hand is facing is where the patient left is automatically. You get, so when you do, because I can remember doing my sideways, I saw like 4 dystrocardias. You get, and you see them walking normal, like living life, and you don't do so. All those things is normal. So don't use because of where the heart is and judge whether it's left or right. You get, now apart from the heart, then the lateral image is obtained with the patient's left side on the cassette. This minimizes heart shield magnification. Now, with your common sense, you should know that when you are doing a lateral projection, you don't just use the right side of the patient and put on the cassette. No, you use the patient's left side on the cassette. The reason is what the heart is tilted to the left. You all know that, and we know that the heart should be closer to the cassette to prevent what magnification. So that is your simple sense to tell you that normally if you are doing on that is if you are doing a lateral projection, the complete name itself is left lateral projection, because people will go and do right and thinking they are getting it correctly. No, you do what a left lateral projection. Now, assessing film techniques. Now, when you are assessing film techniques, I told you that you have to ensure that what there is proper what inspiration. Yeah, so that you can put the diaphragm, push it down. You understand? So you have to tell the person to inspire. Once the person inspires, the diaphragmatic muscles and the rest what pull the diaphragm down, and the whole volume of the lungs will be what visualized. It's very important so that you can mark pathological signs that grows at the base of the lungs. You need to see the base of the lungs, and also in case of pleural effusion and the rest, those kind of diseases that develop from the base of the lung upwards. You get. Then you also check what the penetration. Make sure that your exposure factors are what adequate. Ensure adequate penetration, because you know that the lungs, the chest, sorry, is kind of, it has the contrast in the chest is much. The mediastinum, the heart shadow, and all those, and the lungs. So you ensure adequate penetration to get that soft tissue in the chest you are looking for, and also ensure that what your lungs, you can also visualize the lungs, because remember, if your X-ray beam has too much penetration, you might end up, burning out soft tissue margins that might actually be necessary for your interpretation. Do you understand? Now, the third one is rotation. Make sure that the patient is not what rotated. You can check these through various structures in the chest. One is you have to check for the what steno what clavicular. Remember when I told you about the 10 qualities of a good chest X-ray. Remember that what the sternoclavicular joint was what equidistant. So once they are not equidistant, know that there was what rotation. There was rotation of the what patient, maybe doing when you are applying your image. You get. So now we all said okay, in inspiration, inadequate inspiration, we should ensure that the image should be as well full inspiration. How to know this? One is that the diaphragm at the level, you have to see the diaphragm at the level of the 8 to 10 trips. Remember I told you that when you inspire well, your diaphragm is what pulls down. You get. So you can be able to visualize what the 8 to 10 ribs which are located what below. Now you also have to allow the user to see the intrapulmonary what structures. You get the intrapulmonary structures. Wow. Now you know that when you inspire, you force in more air into your body, and those air will pass through the what bronchioles. Now, when there is sufficient inspiration, these intrapulmonary structures will be what well visualized. You get. So that is another advantage of what inspiring. Just like example, now you can see what I'm saying. Poor inspiration what mimics what right infiltrate. See now that means when you don't inspire well, it will what mimic what an infiltrate. I know that infiltrate, once you say an infiltrate, you're already going towards what a pathology already. You get. So but when the patient now, this same patient with proper inspiration, you see now it doesn't mimic it, because what the air is what sufficient, like the where is what aerated, aerated properly. So you see that now that inspiration can actually lead, if the patient does not inspire, appropriately, you might lead towards thinking that it was a pathology whereby it's just based on the patient did not inspire well. Yes. Now, concerning your penetration, amount of variation required for a quality image. Now, for a PA, you should barely see what the thoracic spine and what disc what spaces. Now, in penetration, what you're trying to tell you now is that now the thoracic spine, you visualize the thoracic spine, but it should not be in such that what it obstructs what the structures you're about to see. You get. So it's just trying to tell that the penetration should be what adequate. It shouldn't be over. It shouldn't be under. If it's under, structures with high dens will obstruct the other ones you are willing to see. Remember, we are not doing chest to see the thoracic spine. It's not a We are not doing a spine radiograph. We are doing what a chest radiograph. So at this point, the spine is not really our area of concentration. We are looking at the chest. So you have to get and use an exposure factor that will efficiently show you this chest and actually kind of ignore the thoracic or spine. You get. Now, and lateral spine should what appear darker as they was move what caudally. You get. That is the spine should what appear what like less dense as they move what caudally in your radiograph. So you have to know the kind of exposure factor you have to pick for such an examination, so as to get a good image. Now, You can see example here, as I said, overpenetrated image. You see now it has burnt out the soft tissue, even the bone itself is kind of appearing dark. Why? The KVP this individual uses what much. So you see now the thing just burnt out everything. Now, if I want to interpret this image, how do I know that now a lesion hasn't been burned out? No, remember, if a malignant tumor is here, I will not see it because it has been burnt out because of what high what exposure factor. And now you can see under penetrated image. You see how it appears. It appears kind of white. Now this image is not a good image for me to what interpret because what the exposure factor used there, the KVP was what low. You get so the contrast is what too like the contrast within the tissues what is too little. I can't differentiate between this tissue and this tissue. It's too like it's little. I can't the contrast is little. I can't differentiate between this tissue and what the other tissue. Do you understand? Now rotation, patient should be flat against a cassette. That is yes, it should flat against a cassette. Rotation of the patient will alter appearance of what the media or sternum. Observe rotation by comparing the location of the what clavicular head. As I told you, the sternoclavicular what joints should be equal distance from the spinous process of the what thoracic what vertebrae. That is, the two clavicles should be what of equal what distance with the spinous process of the what thoracic what vertebrae. Now, rotation, you see now the image here telling you a good normal rotation. That is, this patient did not what rotate. You can see what you see the clavicles, they are what equidistant from what each other. You see now it's equidistant, both clavicles. But here, this one now you can see that both of them are not equidistant. You can see that this person rotated to the right. You can look at if you look at the right clavicle, you see that the right clavicle actually shifted away from the midpoint. You get so it's indicating rotation. This patient actually rotated to the what right. So that is one way of knowing whether a patient is rotated or not. Now we are going over to mass, and remember I discussed this in class last time when I was telling you about mass, infiltrate, consolidation, and the rest. Then moving over to the main lung pathology like bronchiectasis, emphysema, lung collapse, and the rest, and infiltrates and the rest. So we'll go over to now. Look at now. I remember I told you about a mass. Remember, a mass is what a space occupying what lesion. You get it occupies. It just comes and what it appears. Remember, I told you there was a difference between a mass and a nodule. You get, I thought that a nodule kind of is smaller than a mass. I think I gave a measurement of 2 to 3 millimeters or so. Then a mass is kind of larger than a nodule. Now we identify these things using Schiller's sign. If you can remember in class, now you can see that there is a mass in the left what middle what lobe. You can see it there. Yes. Then now come and see an infiltrate. An infiltrate normally occurs during trauma, as I said it before. Occurs while doing what trauma. When a patient is being stabbed and there is accumulation of blood or fluid in the lungs, is what an infiltrate. From the name, you understand that an infiltrate is something that was occupies, like how will I put it now, like fluid. You get infiltration of a fluid or what blood, like you can see here now. You see that it's appearing what opaque. You get, and this patient might be a trauma patient now. And once this patient is a trauma patient, is likely that maybe due to what maybe based on the trauma, maybe stab or person fell from a height, blood kind of left the um infiltrated the lungs, and now the lungs is what appearing what hyper what opaque. Now you can see the lobes or what fissures on the what PA. Now I think in last class we identified what the lobes of, like here you can see minor fissure between the what right middle lobes and right what lower what lobe. You get, so we are identifying the what lobes here. Like you can see B now, showing you that from B upwards is what the upper lobe. You get, then you can see the B in the first image, showing that, giving you an indication that what is the what lower lobe. Okay, so in radiograph, remember I told that it is the lungs is divided into 3 zones. We have the upper zone, the middle zone, and the lower zone. In this zone is what we use to what identify pathologies. You get, and radiographically, the lungs is also divided into what 3 lobes: upper lobe, middle lobe, and lower lobe, which we normally use what the ribs, the counting of the ribs to what identify. You get, so concerning this, we go over to the chest X-ray anatomy. You can see the structures we are seeing there. That is the apex of the lungs, the thyrocartilage, and the rest. All those ones, like we have done them in the last class. Yes. So now we can see the normal radiographic the normal anatomy, and now we are moving over to what the radiographic what anatomy. You can see that these structures are identified what in the radiograph. You can see the left innominate what vein. You can see the aortic arch. You can see the aortopulmonary window, the left pulmonary artery, the left ventricle, the descending aorta. Then you can see the diaphragm, the right atrium, and ascending what aorta, even the superior vena cava. All these structures are very important when you want to what identify what a pathology, or even if you want to identify a normal radiograph. It's very important that in imaging critics you identify these structures. Why? So you know how they appear normally, so that when there is a pathology, you can actually say, okay, yes, this is a pathology. This is not how the aorta is meant to what look like, maybe in the terms of aortic unfolding or any other what pathology in the what lungs, or if there is a mass in a particular part of the lungs, you can actually be able to locate where that pathology is. Do you understand? So that is just it. Now, how to read an X-ray. Now, remember I told you that in reading an X-ray, I think I gave you an acronym, what A, B, C, D, and what E. I give an acronym if you can remember. Now, in reading the patients, you can see that now, first of all, you start with what patient data. Make sure that the patient data is what is correctly what imputed. That is the first thing you check. The patient's name, the history, the age, and the sex must be correct. You get, because sometimes there might be a mistake, maybe a data error, and you see a patient, maybe sometimes you come and you see that this person's radiograph look like a female zone, but what you are seeing in the name is a male zone. That is really telling that there is what a mistake somewhere. Ensure, so because this is a pathology, whatever you are writing for that patient, if it's maybe meant to be for someone else and you're writing for another person, is a very, very what is a clinic, like a clinical malpractice, because you're actually giving someone else what a death sentence, which is not good. Or maybe in clinical practice, if it's in clinical practice, we call it what malpractice. I know that in clinical settings, there's nothing like mistake. It's either you did malpractice or you negligence, one of them. So another one is technique. Ensure that the technique, normally in the radiography, you see that the technique is written there, whether it was PA, AP, rotation, all those things must be there. The special factors will also be there, so that if we are reading the image, we know we are working with a PA radiograph. If it's an AP, because remember, in taking an AP, we should be expecting a magnified heart. We should, okay, if person sees an AP, it's okay, this heart will kind of be magnified in a way. So if I see it, I know, okay, it's the result of the what AP image that was what taken. Now the trachea, it should be what midline or deviated or for any masses. Now, what it's trying to tell you is that now you check the trachea to ensure that normally, if the trachea is deviated, it can be as a result of many things. It can be as a result of what a mass. A mass can be there and what be pushing the trachea to either the right or what the left. And that's that can cause it is when there is a lung collapse. Maybe there is an upper lobe collapse. The trachea or structure will now tend to move to the collapse part to occupy the space there. So once you see it, you're already suspecting what something like that. Now, lungs, in case of what masses or infiltrate. Now, the costophrenic angle should be what sharp. You get it, I told that in the costophrenic angles, that angle between what the ribs, you get between the ribs. Now, if the angle must be what I told you is an acute angle. Now it has to be sharp. If you're not seeing the costophrenic angle, it is depicting something, and it's mostly pleural effusion. You get, remember I told you that pleural effusion is that what accumulation of what fluid in the bases of what the lungs. So if you're not seeing that angle there, that means there is what fluid there. There is a pleural effusion, indicating what pleural effusion. Yes. So now you also indicate for what serious signs, the air bronchograms and what pulmonary edema. Remember I told you that serious sign, what serious signs are. It's actually acts as a guide to help what identify what pathologies. Air bronchogram is when what the bronchioles that are meant to what appear what lucent now is now appearing what opaque due to what displacement of what air with all these infiltrates or fluid, you get, or edematous fluid or the rest. Once is the air in the bronchioles is what kind of displaced because of what due to what pathology, and there are various pathologies that can cause that to start appearing what opaque. Then we have what pulmonary edema, that is what also edematous what fluid in the what in the lungs. Now pulmonary vessels what enlarge. If the pulmonary vessels are enlarged, it can indicate many things. One of the things that are indicates is what it can be due to what high blood pressure, hypertension can cause enlarged pulmonary vessels. Another one I can call it was heart failure. It can cause it because now the blood in the pulmonary vessels cannot be what pumped out of the lungs to the what to the heart and to the other part of the body, and because of that, blood tends to what accumulate there, and the vessels become what enlarged. You get, now the hilar region, you have to also check what the hilar region. Now you know the hilar region, that is the space where what the pulmonary markings what enters the lungs. Now you have to check for what masses what or lymph what adenopathy. Remember I told you that lymphadenopathy is what the inflammation of what the lymph nodes. That the lymph node become what enlarged. I remember when the lymph node become enlarged, just know that and you know what lymph does now, fights infection. Now when it's enlarged, you know that there is an infection at hand, and any pathology can cause it. Even cancers, yes, metastasis can lead towards lymphadenopathy. So once you see that, also was suspecting cancer and the rest. Tuberculosis can also cause it. Yes. Now we have what you look for what enlarged heart. Remember, I told you that when the heart is enlarged, it can indicate many things. Most of the times, it can be what it cardiomegaly. Yet, when the heart is overworked, cardiac failure can lead to what enlarged heart. Now, we have the pleural. In the pleural, you check for what effusion, you check for thickening and the calcification. That is in the pleural of the lungs. The markings of the lung, that is effusion, that is what accumulation of fluid in the lower base of the what lungs, thickening or what calcification. You get now in the bones, you check for what fractures or what masses, that is in the ribs. Most of the when we talk about bones, we're talking about what the ribs. You check for fractures in case of accidents or trauma. Then you check for masses, also check for masses, you get such as osteosarcoma, you get malignancy of what the bone or benign primary bone or tumor. You get now you check for intensive care unit what films ICU, that is intensive care unit films. You look for what line and tube placement. This is very important. The reason why line and tube placement is very important is that sometimes there are some radiograph examination that might require you to what move the patient around, like patient may be moved around, or most of the time we do this before an MRI scan or a CT scan, but mostly MRI sha. We do it so that we check whether there are maybe there are things that were inserted in the patient that needs proper care, or something that we need maybe as an contraindication to a particular examination. And that important thing why we do this thing again is to sometimes after an invasive procedure, maybe due to this tube placement for feeding or nasotracheal tube and the rest, you actually do a radiograph to check, ensure that it was properly placed. You get even cardiac pacemakers, after placing them surgically, we do a radiograph to ensure that what are properly placed. So this is also part of what the critics. Now, it is best to focus on a small area of the film and then scan rather than look at the whole image at once. Now, what is this trying to tell you? That for normally in when you are criticizing a film, it's better you look at a particular location in the film before you start going to other places. Don't just look at a film and start, that's how you look at a film, you just think it's normal. But when you calm down and start looking deeper, you find out that there are some things, some two lesions that are there you didn't even see when you are just assessing it, on a or maybe on a general basis. That's why I told that there are guidelines on how you would assess images. You get there are certain steps on how you would assess what images. So you have to follow those steps. You don't just go and look at the film at once. You get now you can't now we go over to what serious signs. Remember I told you that serious signs are signs we use to what depict pathology. Now look at this one now. You can if you look at there's a serious sign here in the chest. Now you see what right middle lobe. In the right middle lobe, you can see something like a mass there. You get in the right what middle lobe. Now this is a serious sign because it's trying to tell you that normally this thing is not meant to be here, but now it has actually appeared there, and it's now trying to tell that this is what are not is not normal. So in my own instance as a radiographer, what will enter my head as of now will be I'm suspecting a mass already. You get before I now start looking well for that. It can also be an infiltrate. It's also looking like an infiltrate, but for now it's a mass. Then when I now start narrowing down, I can actually get an accurate pathology for this or chest. Just like okay, example like now this one now indicating what air bronchogram. Now tubular outline of an airway made visible by surrounding structures of the alveoli due to what by fluid or inflammatory exudate. Now look at this radiograph. You can see that the lung marking now. This marking is meant to be the bronchioles. On the normals, we don't see the bronchioles, but because of because of the air bronchogram. Remember, air bronchogram is when the what bronchioles are being displaced, the air in the bronchioles are displaced, and we are now seeing exudate, fluid, edematous fluid. Now you can see that it's appearing what opaque in nature. You get so, and the causes of these things might be what pulmonary edema, lung consolidation, severe interstitial disease, and what neoplasms can lead to this was air bronchogram. So it's a sign. Air bronchogram what is a sign that can show you that okay, there are certain pathologies that should be present in these lungs. Do you understand? Now, solitary pulmonary nodule, in solitary pulmonary nodule can be innocuous or potentially fatal lung cancer. Now, remember I told you that nodule and a mass, there is no much difference between both of them. except from the sizes. Nodule is what I think it was 2 to 3 mm. It's small inside. Well, let's look at this photograph now. You can see it now in the left middle lobe. You can see a round structure is depicting a nodule. You can't call this a mass. It's a nodule. Now it's trying to tell you that what when you see this, is depicting what a potentially fatal what long what cancer. You have to always compare to what prior films was for growth, and nodules with irregular borders are suspicious. Okay, now let me tell you this. I think I said it in the last class too. Now, when you see a nodule or a mass, what you should know about these things to depict cancer, a mass that is can be cancerous. If if it's benign, you will notice that the wall will be regular. It won't be irregular. It will have a regular margin or irregular wall. But if it's going to be a malignant something, the word will be it will be irregular. Most of the time, it will be speculated. Sometimes it even appear diffuse. When it's appearing, when you see those kind of signs, just know that there is a high indication of malignancy. You get. So if I look at this nodule now, from my own based on observation, this nodule is benign because if you look at the wall of that nodule, it is what round. It is what the outline is what regular. It is round. So there is no actually any possibility. I've not seen any possibility of malignancy. But remember what you said there. You have to compare it with what other what films. The person has to be coming for radiographs so that you know whether that it's growing, and from the growth, the walls can actually change and it will become what malignant. You get that is cancerous. Now, so over there we talk about what conclusion. Now, lots of information on the chest. Always read the film in the same order. Never skip most prominent abnormality so as not to what miss what certain lesions. You get. So you have to calm down and look at this because sometimes that is what happens. That's why they said normally if you're reading a chest radiograph, it's not also always advisable for only one radiologist to read a chest radiograph. It's good that it is read by 2 or 3 people because what one person might see, the other person might not see it. And it's also advisable that if you're reading a radiograph, don't do it in a hurry. That's why we have what we call a light box. That thing we place that emitting light box we place the radiograph on, so that when we are looking at these lesions, because there can be little tiny micro calcification that you might miss if you just look at the chest on a normal basis. You get. Most times patients come to the hospital for just to do chest x-rays for medical fitness. At the end of the day, they find something else. So it's very important that you carefully look at these radiographs and ensure that the radiograph has acquired, like you kind of evaluate it, examine it to ensure that there is no what subtle pathology or hidden lesion. You get. Because anyone that is hidden that you don't see can be like the effect can be fatal or the consequences can be detrimental in the future. Now, make sure you're always comparing this to the prior examination if possible. That is why in the radiograph, when a patient has done a radiograph, the X-ray images are being stored in the department just in case, especially an examination that needs follow up, so that you have to check the previous one with the recent one to know whether there is any development or whether it's getting worse. You get whether there is any improvement or the it's getting worse. You get. So that is why we actually compare these things so that is part of the base of what critics. Now, um now we will finish this with some common examples which I also gave in class. Now, remember I told you about atelectasis, which is what collapse of the lungs. Now, in here you can see that the base of the lungs, you see that from what I'm seeing now, it is the base of the lungs that collapse. You get. That is even the middle and the lower lobes collapsed. So if you see there, you see that the lower base of the lungs is appearing what opaque. You get. That is the lungs what actually what collapse. So there is no air around that area again. That what you are left with was part of the middle lobe and what the upper lobe. Yeah, so you can actually call this what a lower what lung what collapse. Now another thing, we go over to here, we see what pulmonary what edema. I told you about what edematous fluid in what the lungs, and when there is edema in the lungs, it's mostly due to what fluid or exudate. You get. And most of the time this happens because due to what infection. Tuberculosis can also lead to this. Remember, tuberculosis is an infection caused by bacteria. Now, you can see that the radiograph is what appearing white here, very whitish, and this is actually, for me, from what I'm seeing in this radiograph, I'm suspecting what even TB self, because you can see the diffuse nodular shadows that are here. Then you can now see the thickening at the what apex of the lungs and even at the lower part of the lungs. So you see that this was edematous fluid caused it to what infection. Now, you can see pneumonia, airspace disease, or what consolidation. Now, pneumonia normally, remember I told you that these things come with signs. Now you can see this one. You see a consolidation in the what middle lobe. in the chest X-ray finding, you see airspace opacity, lobar consolidation. When we talk about lobar consolidation, that is the consolidation that is specified to a particular lobe, which is what middle lobe what here. Then you can also see the interstitial what opacity, that is the interstitium of the lungs is what appearing what opaque. You can see it in the diagram there in the arrow showing depicting the what lower what the middle what lobe consolidation. Now, differentiating between atelectasis and what pneumonia. Now, in atelectasis, I told that is what the volume, that is when there is what volume loss. You get